I would therefore very much like to say hello to everybody. If you could pop yourself on mute if you're not me right now, that would be fantastic. So I am Rachel, and a very warm welcome to your Midlands Analyst Network Huddle. Mentioned a couple of times, I do anticipate a certain dog called Eddie visiting me from time to time because his dad isn't here, and he's feeling a little bit fretful and unloved, and it's just not normal, Mum. Anyway, so for any new people, I don't always just talk about my dog, just today, and I do hope you'll find these fortnightly huddles useful because we share skills, we learn from each other, and we share each other's knowledge and experience. But also, I really do think this is just a really nice place to be, and you're very welcome. So there's more info about why we established the network and the role of these huddles in the files section of the Teams channel. And we are always looking to improve the sessions, so we do very much welcome feedback. So just email me if you've got any fantastic ideas, and of course, let me know if you'd like to contribute to one of these sessions as well. Anyway, thank you again for coming today, and it's always great to see you. So in today's huddle, we're going to be talking about inequalities in health in the Midlands and how to reduce them. And we've invited friends from the Office for Health Improvement and Disparities, Local Knowledge and Intelligence team to present some of their work on health inequalities. But before I hand over to our guests, which I'm very much looking forward to in a moment, and I know a lot of you are too, you'll notice that we're recording today's session. And I will also prepare a summary of the session that we're doing today and share with you any slides that are used today. And we're going to finish around about 12 or just before. And if you have any questions or comments, please do use the chat box if you can, although I'm aware that some of you can't. So Menti will be available for you in a moment or two. Please keep yourself on mute unless you want to say anything, just because it makes me sound echoey if you don't. And as usual, these sessions are for you. We like to keep them as informal, but hopefully as informative as possible. But before we kick off, and before I hand over to our guests, could you please go to menti.com? And could you please type in the number 7943 1872, and I'm going to share my screen so you can see that number on my screen as well. There it is at the top, I do believe. And I just have one or two questions for you while we're just getting settled into the room and looking forward to the session on health inequalities in a moment or two, or inequalities in health as people prefer to refer to it sometimes. Okay, so I can see that some of us are arriving at Menti. I'm getting lots of thumbs up, lots of hearts, 7 cats. I do think there should be a dog one. Eddie is most disapproving. Fantastic. While you're all landing there, I'll just got a couple of questions. It's a lovely picture of daffodils first, isn't that wonderful? How uplifting. Spring is nearly here. So the first thing is, and we haven't asked this for a bit, it's just briefly, if you could just type in what comes to your mind as in the main thing that you're working on at the moment. So do you find yourself still pretty much sort of COVID related, COVID recovery related, or is it, yeah. So we're getting quite a lot of responses. Still COVID, inequalities, absolutely. Maternity reporting. Now, maternity, that is something I would really like to cover in one of these huddles. So I think it's something that we haven't covered yet. So I'd be really pleased if someone were to get in touch if they wanted to do a session on that, or part of a session. Okay, yeah. Okay, so we got lots of food insecurity. That's interesting. Regional reports, still JSNA, PNAD. public health intelligence feel there, very much so. Planning, health inequalities, everything you ever wanted to know about medically safe patients. Well, that's fantastic. Well, there's a lot of variation here. Great, and so I can see there's lots of, without asking, there's lots of different organisations reflected here and different roles as well. So that's brilliant. That's really interesting. It's great to have so many people here and so many varied interests as well. Okay, so I've just moved this on because this will allow you to put those questions for our presenters today. But so I'll leave that open for you, and we'll come back to that in a second or two. You can, of course, shout out as well. So I'll stop sharing my screen, and I will hand over to guests. And the first one to talk to us today is Anam. Anam, go for it.
Thank you, Rachel. Hi, everybody. My name is Anam. I'm a public health intelligence analyst with West Midlands. I'm based out of Birmingham, and I'll be presenting on deprivation and health inequalities in the Midlands. So I'll just take a second to share my slides. Okay. Can you see this, Rachel?
Yep, that's perfect.
Okay, perfect. Alrighty. So we'll be discussing the concept of Core 20+5. It's been developed by NHS England. So we'll move forward and look at some of the objectives that we'll be covering today. So we'll be trying to understand what is the Core 20 approach of measuring deprivation in the Midlands. Secondly, we'll be assessing the impact of inequalities on population health through various indicators. And lastly, we'll be trying to understand how this data enables decision-making for the provision of health services. So just a bit of background information first. The Core 20+5 approach is developed by NHS England, and it focuses on three core components. So the first is the Core 20 section, which addresses the most deprived 20% of the national population. And that's been defined by the index of multiple deprivation. So we'll be looking at that in the next slide. And then you will later see this is the focus of our presentation today. And we'll be seeing how targeting this 20% of the national population would impact health inequalities within the Midlands region. The plus component is the plus target population. It's an ICS chosen population group that experiences poorer than average health outcomes and experiences that are not captured by the Core 20 component alone. These are groups that will benefit from a tailored healthcare approach, for example, particularly ethnic minority communities or inclusion health groups. And the last part is the 5 key clinical areas that you'll see on the bottom of that slide. And these are clinical areas of health inequalities that have been prioritized by the NHS long-term plan. So these are specifically, the first one is continuity of maternity care for women in the most deprived areas, and those from Black, Asian, and minority ethnic groups. Secondly, it is the annual health checks for those with serious mental illness. Third is the chronic obstructive pulmonary disease management with a focus on COVID-19. Flu and pneumonia vaccination uptake. Fourth is the early cancer diagnosis. And fifth is the hypertension case finding to minimize the risk of heart attack and stroke in the population. So these three groups, Core 20 plus and 5, they represent the biggest opportunities for narrowing health inequality gaps. And the focus of this presentation will be specifically on the Core 20 component of the population. So before we dive into the analysis, let's take a quick look at the components that make up the indices of multiple deprivation for IMD 2019. So all of England is first divided into these small areas called LSOAs, basically postcodes, and they're ranked into deciles, so 10 ranks. From the most deprived to the least deprived. And based on these 7 domains, which are income, employment, education, health, crime, barriers to housing and services, and living environment, the bottom 2 of those ranks, so the 20% of that total population, is considered the most deprived and can also be referred to as quintile 1. And that's the terminology that we'll be using throughout the presentation, and we'll be calling them the 20% most deprived nationally. So looking at the map of the Midlands, where are the 20% most deprived areas? We used our mapping software and we created a map of the Midlands and labeled all of the LSOAs in the region. And the red that you're seeing here is the highlighted areas where these 20% most deprived region or LSOAs are. And what we're seeing here is that that there's certain urban areas, coastal areas along the coast of Lincolnshire, and ex-industrial communities that have these large concentrations of the most deprived communities. So we're looking at a chart here of all of the UTLAs of the Midlands, and it shows the distribution of all of the quintiles in each UTLA. So what you'll see here is the darkest color indicates the quintile 1 proportion, and as the lighter it goes, it's the next lesser deprived quintile. And what you'll notice here, if you look at the ranking, Sandwell, which is about, as you can see, about 61% of the total population, belongs in that 20% most deprived. And the ones that we've really highlighted here for you to focus on are Sandwell, Birmingham, Nottingham, Walsall, Stoke-on-Trent, and Wolverhampton. These are the communities that have over half of their population is the 20% most deprived. And if you recall, in the Core 20 approach, we are targeting that 20% most deprived nationally. So basically everyone that falls in that quintile 1 proportion would be targeted, and that's been indicated here by the yellow line. So you'll see that it's a different proportion for each area that's being targeted. So meaning that certain regions such as Sandwell, Birmingham, Nottingham, all the highlighted ones mentioned earlier, they have over half of their population that falls into quintile 1, and therefore they will receive a larger piece of the pie as they have a much larger need than others. So, for example, over half of that population of Sandwell was in quintile 1, but if you compare that to areas such as Solihull, which is about 16%, falls in that quintile 1 category, you can see the differences in the amount of people that will be targeted. So overall, in the Midlands, about 25% of the population falls in quintile 1. And the way we calculated this was by taking the total quintile 1 population count and dividing that by the total Midlands population count, multiplying that by 100 to get that percentage, and we found 25. If we were to break down that 25% to see who's taking the bigger chunk of the pie, we see that that is in Birmingham, where about 6% of that 25% is, so it's a 6% of that 25% that is going to be targeted essentially. So how does deprivation influence public health indicators in the Midlands? Deprivation contributes to many health inequalities, as we know, and a way to measure this is by looking at the relationship between deprivation and public health measures indicating poor health outcomes as a result of deprivation. We particularly looked at these 3, so life expectancy at birth, healthy life expectancy at birth, and ill health years. So looking at first life expectancy at birth, sorry, just a distraction. So we first looked at life expectancy at birth for each UTLA in the Midlands. Looking at the map view, we noted that life expectancy at birth for males and females was lower among regions where there were higher quintile 1 population proportions, as noted particularly in Stoke-on-Trent, Birmingham, Nottingham, Walsall, Stoke-on-Trent, and Wolverhampton. The low life expectancy is indicated by the darker shaded regions, and the lighter yellow regions are the higher life expectancy. So to answer the question if there was a relationship between deprivation and having lower life expectancy, we did a correlation analysis by plotting the UTLAs based on the proportion of their population belonging to quintile 1 and the life expectancy that was reported in each of those UTLAs. And not surprisingly, we found a strong negative correlation where R was negative 0.93, and the results were statistically significant with a very, 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 very small p. In other words, as the percentage of population in quintile 1 increases, the life expectancy decreases. Similarly, this relationship was also observed with the life expectancy for females in the Midlands as well. So next, we looked at the healthy life expectancy for males and females and noted similar trends again, where areas that had higher proportions of quintile 1 populations also had lower healthy life expectancy at birth. Again, we did a correlation analysis and found similar results of a strong negative correlation, meaning that higher deprivation in an area, the higher the deprivation in an area, the lower the healthy life expectancy there was in the Midlands. And the relationship, again, was the same for both males and females. So we know certainly that there is a direct relationship between life expectancy and deprivation in the Midlands. But what does this mean from a healthcare perspective? If we look at the chart on the left, the blue line represents the life expectancy of populations plotted by the deciles. So 1 indicates the most deprived, 10 indicates least deprived, and so on. And we can see that the life expectancy increases as the deprivation is decreasing, which makes sense. Similarly, the effect is observed for the red line as well, which indicates the healthy life expectancy. But you'll see the slope is a little bit more steeper than life expectancy, which indicates that healthy life expectancy is more influenced by deprivation than life expectancy. The gap in between the two is the window of need, and it basically it's the difference between the two, the life expectancy and the healthy life expectancy, and it indicates the amount of years that an individual or a population has lived in poor or ill health. So this is a period where people will require treatment and healthcare services for their poor health. So our aim must not just be to extend the life of the population, basically the treatment and care effect, but also through primary and secondary prevention to reduce the time that's spent in poor health. So basically that's the prevention effect, and also to narrow that gap. And in so doing, reduce the burden on treatment and care services as well. The largest gap is at the decile 1 to 2, or the quintile 1 region of the graph, meaning that the deprived communities have most to gain from prevention, and the biggest gain in health can be achieved by addressing this region specifically. So now looking at the window of need charts again for England, considering that this data would be mirrored for the Midlands population, we know that retirement age is around 65 for males and females. However, we can see that in the most deprived decile, basically here, this area, the average age of poor health starts much earlier than the retirement age. So that's about 15 years of poor health before retirement for both males and females. And this lasts for about 25 years, 25 years for females and about 20 years for males. And that's indicated by that black arrow. And as we learned from our previous example, the largest gap is in the most deprived area. meaning that the biggest gain in health before retirement can be achieved by targeting our resources towards those that are worst off. So lastly, this also ties with the concept of proportionate universalism, which is a concept developed by Professor Michael Marmot. And in the Marmot Review, he presented this principle in which he argues that we must spread our resources and our efforts across all communities in order to improve everybody's health. But we must put the most amount of resources and effort into supporting the most deprived communities in order to close the gap. Additionally, those in the least deprived areas will spend a markedly larger proportion of their lives eligible for a state pension than those in the deprived areas. In the least deprived areas. And secondly, only people in the least deprived areas, so about that 20 to 30% of that area, will be eligible for a state pension before they can expect to develop a disability. With those in the most deprived areas spending many years with disability prior to reaching their state pension age. So raising that retirement age, as is planned over the years, is likely to increase that number, or the number of people living with poor health that will be needing to rely on working age benefits for support. So essentially, by targeting that 20% most deprived nationally, also known as the Core 20 approach, we're able to apply the principle of proportionate universalism and address health inequalities in the most effective way. So just some key messages to close it off is by targeting the national 20% most deprived, we may have a more equitable approach as it targets all of those red areas on the map that you saw earlier, where there are more in some and few in others. And this approach may level up the most deprived areas, for example, Birmingham. Deprivation is negatively correlated with life expectancy and healthy life expectancy, where areas with higher proportions of quintile 1 populations were associated to have a lower life expectancy and healthy life expectancy. As a result, areas with higher proportions of deprivation had longer periods of ill health years before retiring and have shorter periods of eligibility for state pension than those in the least deprived. And that is all. Thank you. Any questions?
Thanks very much for that, Anam. I will just check to see whether we've had any questions so far, and we've had 1 or 2 comments already. I'll just share my screen actually, so you can read them for yourself. So here we go. So you can see the first comment is around deprivation, which has a health component confounder for correlation. You're right. Okay. Yeah. So did you want to just look at those comments and see if you wanted to talk to any of them, or shall I pick on one of them?
So IMD deprivation has a health component confounder for correlation. Oh, okay. I think I understand. Yeah. So it's basically it's
part of the score.
Yeah.
Excuse me. Yeah.
Yep. Very true, actually. So Janine can probably also speak to this, but we were looking at child poverty and how it correlates with deprivation, and we found a very strong correlation. It was about 0.96, and then we later realized that it's because it's part of the definition of IMD. So I think that's a really good point, that health is a confounder for correlation.
And I think so IMD has got mortality indicators in the component of building it, but it's still it has so many other variables, and this is the way that we're having to describe populations in terms of deprivation, and this is how we're kind of how it will be focused through the levelling up agenda. So, and because NHS EI have defined it using the IMD, and the IMD is the best kind of indicator of multiple deprivation that we've got. It was a game changer when we started using it 20 years ago. So we completely take on board actually some of the build of life expectancy and IMD are the same, but this is the way that we need to understand our populations to target them for levelling up. So that's the way that we kind of need to focus it. So yeah, completely take on board what you're saying, but it's an important indicator that we need to use to look at what we're doing.
So the next point reads retirement age 66 will be 67, 68 for most of current cohort. Yeah, so as we saw, that retirement age line, the higher it goes up, the more it will impact those that are most deprived, because it will take them a longer time to reach that, and they'll be living in a larger or a larger portion of their life in disability before they reach that point. It's a good point. And MD and health component can use instead of income deprivation removes health confounder. It also removes the, yeah, is true.
Shall we move on, because we've got another 2 presentations to get through and pick up? So one of the questions is about where the data's come from, and a lot of the data's come from fingertips, and Laura was going to give us a quick run through the latest updates on fingertips.
Yeah, absolutely. So what I was going to suggest is I'll have a look at these comments, and we can share them with our presenters afterwards, and if we can put those responses on the Teams channel, or we can share those later. But yes, we need to move on. We need to move on, and we do have some of the answers to some of those questions here. So I will now hand on over to Laura. Laura.
Wonderful. Thank you very much. I take it you can all see the presentation there.
Yes.
Wonderful. So this is going to be just an overview of the recent updates in fingertips at the moment. So with such a professional and experienced audience, I'm sure you're all used to fingertips, but I'll just go through a few of the things that have changed recently, just in case you're like me, you land on it and then have a panic that they've taken something away, but it's actually still there. So there's new branding. We've gone all black now with the Office for Health and Improvement in Disparities. But the idea of slightly rejigging the homepage is both to reflect transition from PHE to OHID, but also to have a slightly cleaner and more easy to navigate front page. So hopefully you'll still be able to find all the things that you want to find, but it'll look a little bit cleaner. So with all of these changes, all the pages are still there. In fact, some things have been added, nothing's been taken away, but you might just have to click through a few additional menus. So if you scroll down on the first page, there's now on the home page, there's now a section for fingertips guidance that you'll see down the bottom there. And that actually contains quite a lot of useful information. So if you don't have a regular webinar on updates, you'll be able to find lots of things there. So if you go into fingertips guidance, it will give you a lot of information about where to find other information. So in there, if you're a new user or you're trying to teach somebody else, there's a fingertips user guide, which is really helpful, and it's a PDF document that takes you through a very sort of basic introduction to fingertips, but also some more advanced capabilities. There's also a really helpful section on new features. So you can see both the data that's been added, but all sorts of other functionality that's been put in there recently as well. And there's also a new page about geography, which I'll go into in a few minutes. This is quite useful, I think. So if you go into the inequalities data view, so the top left there, just under public health, if you go to the inequalities view, you'll be able to see that there's not just single time periods, but where there's sufficient data, there's trends over time. And I think for many indicators, particularly as you can see dropping off there in life expectancy over the last couple of years, it's really good to do that sort of overview trend analysis. I think obviously if you're doing the type of analysis that Anam is talking about, it loses the accuracy slightly, but I think it's really good for a regional overview, and it's good if you want to have something handy to put into reports. As I say, a lot of the things that you'll be familiar with are behind other things. So now if you look at the area highlighted there, if you click on the legend or the benchmark or more options, you can find all the information that you would be you would expect to find there. You just have to click on a few menus if you can't find anything. So if you look down there, if you click on benchmarks, all the comparators there are still there. So you can benchmark still against goals. You can do an all England comparison or an all in your particular region comparison there as well. And then if you want to, as I say, export an image or a table quickly for a report, it's under that more options tab there. So you can still use that easy export option if you just need something for a presentation or a page of a report there. So all the things that you hopefully have been using are all still there. You just have to click through a few more things. It's just to make it a bit cleaner so you can concentrate on the data a little bit more. And this is the one that always gets me a little bit. I had to email a colleague about this the other day. If you want to do the comparisons for the SIP for nearest neighbours analysis, so analysis of areas which are similar in socioeconomic characteristics, you actually have to change the geography there. So you have to click back so you get the districts and unitary authorities pre-April 2019 geography. So the latest is up to 2021, but you have to click back in order for that option to appear there. So I thought that the option to include that comparative analysis had disappeared, but it's actually just because it's calculated only by a previous geography. So that's just a little technical thing there if you're looking for it. Oops, and a spelling mistake as well. All the menus are there between these three different sections on at the top of the dashboard there. So if you look at the top left there, you'll be able to get all the things that you'll be used to seeing. So the overview tab is the most useful, but you can go and find any relevant reports. You can get box plots diagrams, you can compare areas, etc. All the things that you're used to seeing in Fingertips are now in these drop down menus at the top. So that's what you can get there. Then again, with all the geography, that's all been shrunk down, and this was, I think, about sort of 5 or 6 months ago now. So hopefully you'll have seen it and been navigating around it. But all the geography is still there, so you can choose the geography that you want to look at, then go into regions, an area, and so on. And all the options are still there, so you can quickly change the different geography there. And then in the public health outcomes framework, these are all the different areas in the FOF. So you can have a look at the overarching indicators or go into wider determinants and so on. And it will give you all the indicators listed in those sections of the FOF. So everything is still there. And as you all know, you can't really break Fingertips. So just keep clicking around until you find it, I think. And the last thing I wanted to update people on is this page from the Fingertips guidance at the beginning about geography. And it gives both geographical updates, and I think that's particularly important when we're looking at changing geographies with ICSs and so on, but also a history, a log of where geography has changed. So if you're doing any historical trend analysis, that'll be able to give you a lot of information there too. But I think it's just really helpful to have a page where everything's there on the one page. So if you are doing, if you are searching for updates or if you're doing trend analysis, the information will be there for you. Fab. I think that's about all I have for you this morning. So hopefully I've given other presenters a bit more time, but I'm very happy to field any questions now, or if it would be useful for any other groups to have the presentation. You know, we can have the slides, or I can do another presentation in another venue.
That's great. No, thanks very much, Laura. So I'm just kind of, I was looking at our audience really, and I know that there are some experienced users, like you say, but many people don't use Fingertips. They don't really know what it's about. So I think it's really useful, and it's an excellent tool. It's an excellent resource, and it's developing all the time, as you say, even if some of the developments are a bit confusing. I'm not going to look at the questions in case there are any, because I'm going to move. But thanks very much. I'm going to move straight on to Janine, and Janine's going to tell us about some of the findings from the West Midlands Disparities Report. So Janine, thank you.
Hi, am I sharing screen?
You sure are.
That's fab. I've got Rachel as a big person in the screen that I can see. So hello everyone, I'm Janine Della. I head up the Local Knowledge and Intelligence Service for the Midlands, which is part of the Public Health Analysis Division at the Office for Health Improvement and Disparities. And if that all sounds really jargony, just think of us as we used to be Public Health England when life was much simpler. This isn't my work. Zach was due to present to you today. This is his work, it's his report, but unfortunately he's off sick. And rather than cancelling, I've spent this morning pulling together a really quick presentation from his report, which sits on K-Hub in a nice whizzy HTML format. I've screen dumped it into PowerPoint, so it's not particularly slick. Hopefully it'll be interesting, but I just want to just give you some context there. And all I'm going to do is just run through some of the findings from our disparities report, which focuses on ethnicity in the West Midlands. Oh, let me just. So why have we done a disparities report? So we within the West Midlands, we've got the West Midlands Combined Authority, and the Health of the Region report in 2020 highlighted significant inequalities in health outcomes for people from ethnic minorities. So this report is an attempt for us to start to explore those disparities through the data. So we've published it on the Midlands K-Hub pages. It's open access, but you do need to register with K-Hub in order to be able to go and access it. And we've really used it to try and storyboard through some of the inequalities in health outcomes through our ethnic minority populations. We are very constrained by the data that's available. So the way that we can break the data down, we can only look at data where it is available for different ethnic groups. And for that reason, this report is a report for the West Midlands regions, not for the West Midlands Combined Authority, because we've got a little bit more data at that geography than we would have if we took it down to the Combined Authority level. But we have got a growing number of data sets that allow us to look at data by different ethnic groups. So I do think it's useful just starting to share this and getting people to think about the data in the way that it's presented. In terms of what we're going to do with it, we are looking to develop a BAME and disparities work plan for OHID Midlands that will help us to start to work with local systems to target strategies that are specifically aimed at reducing some of the disparities in health that we've got in our different ethnic groups. So just in terms of the population and the demographics of the West Midlands, across the West Midlands as a whole, 83% of our population are from white ethnic groups, compared with 86% of the England population. So we've got 17% of our population is from ethnic minorities, which is only actually 3% higher than the England average of 14%. And the populations in the West Midlands are concentrated into the Pakistani and Bangladeshi communities with nearly 5%, the Indian ethnic group with 4.6%, and the Black ethnic group with 3.9%. So we've got significant Asian and Black populations across the West Midlands that we are starting to understand some of their disparities in health outcomes. I'm just going to run through some of the health improvement indicators that we've got. So this is the prevalence of obesity by ethnic group in reception age. And you can see very quickly that actually children from Black ethnic groups have a much higher rate of obesity in that reception age children, both for the Midlands and for England as a whole. But I think more importantly for the West Midlands, we have got significantly higher rates of obesity in those reception age children than England for the white and the Asian populations. It's just we've got higher concentrations of obesity in the Black population. So you can start to see it's actually quite a complex story that we want to try and unpick and understand. When we look at smoking, smoking's actually much higher both in the West Midlands and in England for white ethnic groups, other ethnic groups and mixed ethnic groups. We've actually got lower rates of smoking prevalence in our Asian and Black populations. But when we look at the proportion of physical inactivity across our populations, we've got much higher rates of physical inactivity in our Black and Asian populations. 1 in 3 of the population in Black and Asian ethnic groups are physically inactive. And for the West Midlands as a whole, we've got significantly high rates of physical inactivity compared to England. This is something that we see as really significant in the West Midlands at the moment. We've got the Commonwealth Games coming to us in the summer, so it's a really good opportunity for us to start to think about targeting some of our public health interventions to maximise the Games from having the Commonwealth Games, to try and actually increase the proportion of the population that are getting some physical activity and moving people out of that physically inactive category. So we're starting to think about how we can use this data in that context. Just quickly moving on into thinking about how does this translate into health outcomes, and I've got absolutely no idea whether that slide will show on your screens at all, but what we've done is on this slide you can see our directly standardised hospital admission rates by ethnic groups for the West Midlands compared with England. And first of all, our hospital activity rates are significantly higher in the West Midlands than they are for England as a whole, but they're particularly high in our Asian population and our Black population. So people from Asian and Black ethnic groups are going to hospital as inpatients at much higher rates than they are for people from other ethnic groups, but also than England as a whole. And this discrepancy gets even bigger when we look at hospital activity for emergency care on its own. So when we strip out the planned care and just look at emergency activity, we have got much higher rates in Black and Black British groups and much higher rates in the Asian groups than we have for all ethnic groups, but also than the England average. So we're starting to tell a story about what's going on across different ethnic groups. We haven't started to think about breaking this down by different diseases and different causes of admissions and starting to paint that picture through. And clearly, the more we break the data down, the less likely we are to get statistically significant results. But we're starting to unpick and tease out this story. And we can't tell a story of health in the Midlands without looking at COVID-19 and thinking about what's happened with COVID-19 for our ethnic groups. And we know that different ethnic groups have worse outcomes from COVID, but we also know that we have significant ethnic inequalities in vaccination rates, case rates, hospitalisation, mortality rates in both the West Midlands and England. And I've just pulled a couple of charts through from the report to give you a flavour. So for first dose vaccination data, we have got significantly lower than white ethnic group. We've got significantly lower uptake of first dose vaccinations across all age groups and all ethnic groups when compared with the white population. The Black ethnic group have the lowest first dose, and the Black ethnic group have the lowest first dose vaccination rates for all age groups. So we're seeing really significant variation by ethnic group across all parts of the kind of COVID pathway. And just kind of finishing with the COVID-19 mortality rates for the West Midlands and England by ethnic groups. So across the Midlands, white, Asian, Black and mixed ethnic groups all have significantly higher mortality rates from COVID than England do as a whole. But we've also got higher rates, but we also know that the mortality rates are highest in the Asian, Black and mixed ethnic groups than they are for the white. So I think this is starting to kind of shine a light on the complexity of looking at disparities in health outcomes by ethnic group. Ethnicity is clearly not the only driver that we've got for disparities in health, and all sorts of other things will be driving it. but we know that the West Midlands has a more ethnically diverse population than the England average. We have got higher rates of childhood obesity and physical inactivity in people from ethnic minority populations. We've got higher hospital admission rates in our Black and our Asian populations, and it's particularly evident in those emergency admissions. And we know that we have got significantly worse outcomes from COVID-19, but we also have significantly lower uptake of COVID vaccinations in our ethnic minority populations. So I just wanted to share where we've got to in terms of working the data through. For more information, do get in touch with us using the West Midlands inbox, or do go and sign up with our K-Hub pages. And there's a link to the report there, but you do need to be registered with K-Hub to be able to actually get through and access the report. So that's all I really wanted to say. I don't know whether it was really quick and it was quite hastily put together, so I hope it was vaguely coherent and useful. I will pass it back to Rachel to go and see if we've got any questions.
Yes, thank you very much, Janine. It was much more than vaguely coherent. Thanks very much. Now we do have some comments. So instead of sharing my screen where you'll be presented with lots and lots of words, I'll just read a couple of comments and a couple of questions out. And if we've got time, I'll go back in time and I've got 1 or 2 questions around the fingertips presentation as well. And if I miss any, I will do what I said at the beginning. I shall pursue them after the session. So one comment is around Witt's question: what does this all mean for those of us who work in acute trusts? So I'll just park that there while you think about it, whilst I make a couple of read out a couple of comments. One of them, somebody's asking whether the slides will be shared. We will share the slides afterwards. So somebody has commented around physical activity is so closely related to environment that evidence about why this is and how to increase physical activity rates should be examined before lurching forwards behavioural individual level interventions. So I think it's just there are so many ways that you could respond to this type of information, and what to do, where to focus your efforts, and so on. Well done, Janine, for a last-minute cover. Yeah, I concur. Me to Janine. Janine, can you do this?
Can I? The acute trust one is
Sure.
interesting. So,
yeah.
The thing that drives the hospital admission happens a long time before the person gets admitted to hospital. So it's much more complex than who presents, and I think for me it's understanding how we can use the population health management agenda to understand things across the whole pathway, to understand how we work with our healthy population. So going back to the fact that our Black populations have higher rates of childhood obesity at age 4/5 in reception, those children are more likely to develop type 2 diabetes in young adulthood. They're more likely to have cardiovascular disease appearing earlier in life, and they're more likely to kind of be suffering from ill health much younger than kind of people who aren't presenting as being obese in reception age. So it is a whole pathway, a whole societal kind of need to understand the things that are driving people's health needs and how we work together to address them. In terms of culturally, it has a huge significance for how we deliver services in acute care, in terms of making sure that our services are culturally appropriate, that we've got the right pathways in primary care, that we've got the right join up and the right kind of messaging going out to people, and culturally appropriate services across the whole of that pathway. And I think it's far more complex than what can an acute trust do. It needs to be how do we work together as a system across our integrated care board, kind of area and through our primary care networks to actually design whole population approaches that will actually start to tackle the root causes of inequality as opposed to dealing with it at the front end. So I think, so I'm not saying there aren't things that you can do as an acute trust, and having never worked in an acute trust, that you moved me straight into an area of discomfort there. But for me, it's about thinking it through from that population health management perspective, and actually how we understand all the driving forces of ill health and the things that drive people to access services, and actually how we work as systems to address them.
Yeah, thanks very much for that, Janine. So reflecting on that, we have, of course, in the strategy unit, we have done pieces of work around the inequality of access to elective care, for example, in acute trusts. So Stephen Wyatt did that piece of work last year, and we've done going to be publishing a follow-up piece of work, which is about, so that presented those issues that we see and we know about, with some surprises. And the follow-up piece of work to that is, what do we do about it? What are those strategies that we can adopt to do something about those challenges? And of course, we have national guidance on how to just remove our waiting lists as well. So there's and part of that is to address inequalities in health at the same time. Okay, that's great. I'm just going to read a couple more comments that we've had. So one of them is says a fear of this type of inequalities in health analysis is that it keeps telling us the same thing. I mean, this is true. So this person is saying it's not important, because it is, but of course, but how does it lead to action? So that's you covered some of that in what you just said before. We're not saying this is groundbreaking news. I think as part of this is, this is just making sure that we are really getting as much value and information and insight that we can from our data, and making sure that we do use it. So another comment is ethnic inequalities were very apparent before vaccinations were available, so it's important to not to assume that any worse outcomes are as a result just of that. It's all part of the picture. And let me just pick on one last one. I don't think we're going to have too much time to go back to the fingertips couple of questions, but people did have a few questions about fingertips, so I will pass them on to Laura, and I will email the answers out to everybody as well. Let's see this final one. There's a question, sort of finally, this is my question. We may not know the answer, but there's a question around the data quality of the coding of ethnicity. People probably, I mean, that varies, we know that varies, but quite often it's not stated, so we don't necessarily have an accurate picture of what that profile is of ethnicity.
No, but I do feel really strongly that we need to move away from wanting perfect data to make decisions on. We know that there are inequalities in health outcomes. We know that there are that it's multifaceted and complex, but inequalities in health outcomes because of somebody's ethnic group, if they are preventable, they are unacceptable, and we need to make the best use of the data that we've got and make the best decisions that we can with the data that we've got available to us, and do what we can to address them. So I completely take on board that there are huge issues with data quality, and it really is a barrier in that we just don't have enough data by different types of protected characteristics, but we need to actually try and move things forward by making decisions based on the best data that we've got. I'm just going to ask Carrie if she wants to come in, because she popped her hand up, and it's so nice to have somebody pop their hand up in one of these. You're on mute, Carrie. You're still on mute.
Maybe she's not able to. Is there something we need to do to Carrie?
Have we forced Carrie to be mute?
No, not deliberately. Don't say things like that. No, there may be just something. I saw a couple of comments earlier on that not everybody has equal access to the functionality of some of these Teams calls. So Carrie, so sorry. Thank you for trying. Do come back to us later with your comments, and we'll be delighted to see what you have to say. I don't know whether you're able to type. Okay, well, we will follow up. We will follow up. Okay, well, that's we're approaching the end of our session today, and I did want to finish in time to be able to say thank you so much to our guests today. It's a huge topic. It's enormous, but that means it's a very, very important topic, and I think we've had a nice coverage of picking out some of the key issues. And if you're not familiar with Fingertips, do go and check that out. It's an extremely useful resource. I've used it an awful lot over the years, and I can see from the comments that a couple of the changes have confused people. So maybe there may be some further revisions to help people get the most out of those. And just finally, if I could just let you know what's happening in the next couple of huddles. In the next huddle, we are going to be looking at a bit of a contrast. We're going back to, this might change actually. I've just had something to say. This topic might change, but it'll definitely be our health economics unit friends who are going to come back and talk to us, possibly about data engineering. It may be as something else. We've got Stephen White who's coming. Actually, no, I forgot this in the wrong order. This is Stephen White next time, I think. And we've got the Health Foundation. We've got Fiona Grimm, and they're going to be coming to talk to us about their networked data lab, and that's in about 3 huddles time. And then, really importantly, we've got David Callahan from Strategy Unit is going to talk to us about the integrated. What actually does that stand for? Integrated care system. My mind has just gone completely wrong. How ridiculous. Thankfully, we're not recording this session. Oh, yes, we are. Anyway, the Integrated Care System Intelligence Function Guidance. And I think we're going to be having a bit of a panel on that. I fancy a chat about that. I think we're going to get a few people around the table on that one, because I think that's going to be great. So thanks very much for coming, everybody. Thank you, Janine, again for stepping in. And see y'all in a couple of weeks. Bye-bye.